morning. I'm David Coates. I'm pleased to welcome you to the SITH3, the third iteration of our conference on healthcare IT and the security and privacy issues. In the past, the prior two workshops, we really focused on security and privacy in healthcare IT with a little bit of mHealth. And this year, I suppose we've kind of flipped the emphasis. It's about mobile health with a little bit about security and privacy. And it's really fun to have such a diverse group of people from a lot of different backgrounds in health, in technology, in government, in academia and industry together here today to talk about some of these challenges. So apologize for the little delay in getting started. We have a guest in the room, virtually speaking. Misha Pavel from National Science Foundation is joining us by Skype, at least for the first session or two. And again, I'm David Coates. I'm a professor of computer science and associate dean of the faculty for the sciences. And I wanted to introduce and thank my co-organizers initially. That would be Andrew Campbell and Lisa Marsh, who are co-panel chairs for the first panel. Eric Johnson from the Tech School, who's doing the second panel. I'm doing the third panel. And now it's basically because Andres is, where is Andres? There he is. Andres is postdoc in computer science.
Yeah, I'm just not hearing it. Sorry, Larry.
So Andres is leading the fourth panel. And I also very much want to thank the people who really make this happen. Tom Candon and Karen Page from ISDS. Leslie Tate from the Center for Digital Strategies here at Tuck. And of course, Larry Bassett, the indefatigable tech guy who's trying to pull all this together at the last minute. So we really appreciate their help tremendously. I also wanted to, I don't know if I can advance my slides here yet. I wanted to thank our sponsors, in particular the National Science Foundation, which provided a conference award that has supported the cost of running this workshop, and Dartmouth College through its Dartmouth Conferences program, which has also provided financial support. The ISDS mentioned earlier is the Institute for Security, Technology, and Society. This is a cross-campus research-oriented institute that sponsors a lot of programs around the intersection of security and technology and society, and Denise Anthony is the director of that. Also, we have a lot of support from the Center for Digital Strategies, led by Eric Johnson at Tuck, and the Center for Technology and Behavioral Health in the medical school, led by Lisa Marsh. So I really appreciate all of their support in pulling this together. I don't want to spend a lot more time because we have a really exciting and very busy schedule. I will mention 2 or 3 logistical things. First of all, the restrooms. Always good to know where those are. The men's room is actually right outside this door, or you can go around the corner from that door. The women's room is further down the hallway in that direction. You go follow the hallway around and then take the first left. If you want to use the wireless network, you're welcome to use Dartmouth Public. You may have to open your web browser and agree to some terms and conditions. Of course, that would be during the breaks. We don't want people engaged in stuff during the exciting panels. And then thirdly, just a reminder that we are recording the presentations and the Q&A, so your questions will be recorded. We're both in video and audio, and we hope to post those on the web after a few weeks. And we have some student scribes who are taking notes, and we'll be preparing a text summary of the workshop for presentation online and hopefully in IEEE security and privacy as well. So with that, I will hand it over to Lisa to introduce our keynote speaker.
Good morning, everyone, and welcome. We are very honored to have Dr. Wendy Nilsen here as our keynote speaker this morning. It's my privilege to introduce her. Wendy is a health scientist administrator at NIH's Office of Behavioral and Social Sciences Research. And she is arguably the main, I think, one of the main leaders at NIH in everything mHealth and wireless, and has really launched lots of creative initiatives around funding opportunities, around think tanks, around public-private partnerships around this, around conferences all over the country and internationally around mobile and wireless health. And I know we'll be hearing a bit about that today. She also, in addition to that work at OBSSR, leads a trans-NIH initiative called the Adherence Network, which is focused on providing leadership and vision for adherence research at NIH, and also has a very strong interest in chronic physical health conditions and the application of technology to that. So I promised her I'd be brief with the intro, but we're very honored to have her, and we welcome her.
Good morning, everyone. Good morning, Nisha. Good morning. I made Lisa do that shortly because nobody wanted to hear it all. So it's morning, it's great, it's very cool. I am so excited. I was here yesterday. I was hearing about wonderful projects. It's just amazing. So this is very exciting. I'm going to just tell you a little bit about kind of the stuff we work on at NIH, the questions we're asking, the kind of things we're worried about, including privacy and security, but there's a whole range of issues that we're worried about and that you can help us solve because we count on you all to be the genius for us. So just let me tell you who we are, because we're the Office of Behavioral and Social Sciences Research, and everybody says, you know, why do you care? Why is that important? Why is this an issue for behavioral, why is wireless and mobile technology important for the Office of Behavioral and Social Sciences? And I'll tell you, it's because behavior and social factors are in everything we do. And if we just build cool tech, I set my alarm for the wrong time. I meant it for 30 minutes, I set it for 1, so all right, my tech has failed. But I'll use the clock on the wall. Wow, what a cool idea. It's a new phone, you know, you have to get the newest one and then you can't figure out how to work it for a while. So, but we really feel like there's behavioral and social factors. I think, you know, Patty Michelle's talk last night about security and privacy. These are behavioral and social factors that we need to consider in everything we do, because we can build really shiny gadgets. And when I started, the people were just whipping out these super shiny gadgets and saying, look what I built. And I was like, did you talk to, you know, somebody actually was emailing cardiac events to nurses in the first conference I went to, and I was like, email and cardiac event. What's wrong with that picture? So, you know, we really have to work together. And the thing is, I guess my thing is we need to work on both sides. You know, we need to have, well, not both sides, all sides. We need medicine, we need behavioral and social sciences, we need engineering and computer science to come together. And then we're going to really be smart. So, you know, when I think about wireless, I think about the ubiquity. I mean, I love these pictures of the world lit up, but, you know, most of this, in the developing parts of the world, this is all wireless. So thinking about, you know, how these things are growing and here. But in NIH, we think of mobile. I know people have carved this down to there's a wireless world, there's a mobile world, there's an e-world. Somebody said lately, let's just make it digital. I don't care. We don't care. At NIH, we're really not that turfy. And, you know, as the world's biggest biomedical research agency, we can be snobby and just say we don't care. So it's everything. So we think it's phones, we think it's sensors, we think it's monitors, we think it's industry-developed products as well as you know, when you're doing the science as well as academics. So really, we're looking, you know, we really just think it's good ideas to improve health. I also think people have said to me, I've gotten hit with this all the time, isn't it just telemedicine? I was just in a meeting with Health Affairs and they said, yeah, it's telemedicine. And telemedicine is very cool, it's great, but it's very restrictive. And actually in the US, it's a billing category, right? It has very specific rules. But I also think that mobile and wireless is very different conceptually, because telemedicine was about a healthcare professional working remotely with the patient. And mobile, you don't have to be a patient anymore. You can be a person. I mean, we're only a patient when we're in healthcare settings, although us in health have forgotten that. We think you're a patient 24/7, but you're not. You're only a patient when you're in clinic, even if you're a patient then, right? You're a person first. And I think mobile gives us a chance to really beyond that point-of-care diagnostics, that point-of-care treatment, really thinking about scaling, bringing health to where people are, and measuring health where people are. Continuous data sampling. So no more of this, we're going to go for an annual checkup or we're going to measure people every 6 months. It's not about the researcher's schedule or the clinician's schedule anymore. It's about measuring in real time. And really, to me, there's this real joy in mobile in enabling patients and caregivers to instead of saying you will do what we say. I run the Adherence Network. As Lisa said, it used to be the compliance group. We've changed that. We're going to shift it out of adherence pretty soon too, because I think that's not a good word either. But I think, really thinking about how do we change the systems? How do we change health so that people want it? That people are looking for ways to improve their health, and in ways that are not snake oil, but are really good. And then it's real time. So I think that there's a real difference between telemedicine, and you're going to hear this, and I think there's some issues going on in that, but I think thinking about this more broadly, so it doesn't get co-opted as just medicine and just provider-driven. I also think, I love Jay Parkinson's comments on this, but thinking about doing this correctly. I met with people here yesterday. I was so impressed. A medical anthropologist working on this. I was like, whoa, it's so cool. We need these multidisciplinary teams because we think we created this cool thing. I met this very brilliant young doctor who said, I'm going to solve the obesity epidemic. I said, well, that's cool. Great. How are you going to do it? He said, well, every time people are getting ready to eat, I'm going to have them enter their food and they'll see how many calories it is. I said, well, that's nice, very nice, well done, but do you know there's a whole research literature on that? And Joe Smith from West Wireless would always say, I can look in the mirror, I can look at my waistline, I can listen to my wife, and I know I'm eating too much. I know I'm not exercising enough. But so what are we going to do that's going to add value? And I think there was a question last night about privacy and security adding value. I think we need to think about how do we do this right so that people want it, not that we're the medical system and slapping it down on you, but the people are saying, I want what you have. We need to think about that. They're consumers. I said, the potential they think here is huge. I was just with Jay Sanders the other day, and he said, you think about all of the things. He's a longtime telemedicine guy, and he was saying so many things that we measure in clinic are so dependent on environment. So if I'm doing a spirometer for asthma in the clinic, well, this kid's living in a house that's infested with rats and mice. Well, you'll have an asthma attack in that house the clinic, where there are in theory, no rats, no mice, is probably not a great place to be measuring respiratory function. So we can now really think about taking the lab, taking the hospital, bringing it into the home. Eric Dishman from Intel also talks about shifting left, moving health from the hospital and the care settings into the home. So the sicker you get, the more likely you are to stay home. Seems to make sense. It's just not the system we've grown up with. So thinking about that. And I also think we can really change the questions we're asking. I think many of you have been pioneers in this area, but we're asking questions now that health never asked before. And then we have remote clinical trials. I'm really excited about the possibility of doing remote trials where we can work with people who are not next door to an academic medical center. And if you're in Dartmouth, then you seem to be a little bit in the middle of nowhere. I'm sure you like the idea of being able, but isn't this fabulous that you could do a trial with people that are around the world? With remote wireless, we can think about that, and we can monitor people, and we can do all sorts of things. So it's exciting. But I think, as NIH, I have to tell you, I drank the Kool-Aid. I love mobile. Everybody that knows me will tell you, yes, Wendy drank the Kool-Aid. But you know what? This is from my friend Al Shar, who was at Robert Wood Johnson. We're huge hype. Every day, we're going to save the world, da-da-da. We may, I hope. And, that's why I'm here. That's why I do what I do. But, we really have to get the science going so that we can really come up with, we can get out of the realm of potential snake oil and get to the realm where what we all want. And I think that industry wants, because I work with industry all the time, they want to get to the point where they can make money, but they can also create devices that change people's health. So in NIH, we think of these as a continuum of tools. I'm going to tell you some of the things that we work on, you all work on, we fund. I get to take credit for you then. It's really cool. See, I look uber smart because I hang out with all of you. But we think about it, measurement, diagnostics, treatment, but we also, my global friends at Fogarty International Center at NIH we keep global separate so that we remember, global has a lot to teach us. Not only do we have to think about global from our perspective, but there's a reverse technology transfer. that can happen, because they're doing things that we're not. We're kind of behind in a lot of things. We're doing really great work, but there's a lot of things that's happening in the rest of the world that we really need to think about. So considering global and thinking about some of the things that are happening there. So when we think about measurement and assessment, at NIH we fund things like implantable biosensors. These are very interesting, very fun. There's just, I can't even begin to think of how many are being developed now. But in terms of research, in terms of clinical, thinking about, this is one from Diane Burgess at University of Connecticut. But this is a multi-analyte sensor. There's many of these being developed. But this teeny little thing goes under the skin and stays there for 30 days and measures all sorts of things. So if we want to know about metabolism in real time, here it is. I mean, these are not ready for prime time yet. They're still being finalized. But think about 1 month of continuous measurement. It's just amazing. It's really high potential. This is Diane Cook from Washington. She does aging in place. I mean, I think we think of wireless aging in place as wired, but if you go into these places now, aging in place is as wireless as the rest of us. I mean, I think the opportunities are all there, and not thinking about a world that's wired and wireless either, because, as my friends at Qualcomm tell me, the wires are all leaving. So, how do we think about, a world where wired and wireless blend seamlessly and integrate well? And we have a lot of seniors coming up, and I'll tell you, they all say they want to stay in their home. It's up to you all to keep them there. This is Kevin Patrick at UCSD. Kevin has done so much work with the PALM system and his team to really be able to do physical activity and location sensing. So really being able to measure this on population level. So these have not been able to be done before. This is Vivek Shetty, who I work with a lot at UCLA, but he does biosensing, and he's a dentist who watched people come in with their face ripped off. He did reconstructive surgery for poor kids in LA who had gotten shot in the face, and you have to reconstruct their jaw, right? You have to reconstruct their oral stuff, and that's what he does. But he was wondering, he went to psychiatry and said, how do I know if they're going to get PTSD? Isn't there anything I can do when they're in surgery in the emergency room? And of course, psychiatry said, no, we can't do much there, So he started on this hormone detection to be able to do cortisol in real time in a wireless way. And anybody who's swabbed people knows that this is just so cool. When we think about diagnostics, NIH, we built some very high-tech cool toys. Lucas is not a toy, obviously, but I think Lucas is really cool. This is out of UCLA too. But I think that what's really exciting is this is a sustainable tool. The $2 lens clipped on a phone to be able to do diagnostics in the real world. So if somebody comes from their village and feels like they're sick and has something or going on, do we really want to sample and then send them home? Are we going to see them again? I mean, and this is where remote technology transfer comes in. Do we really want to do that in the US too? I mean, in the rest of the world, we're much more acutely aware of it, but I know I worked with urban kids that were in the child welfare system, and if you saw them once, it was great. If you saw them twice, it was a miracle. I had to go out and look for them. So, if you can do things in real time where they're at, it's amazing. So Lucas allows for that opportunity. This is a tool that we didn't fund that was just brought out, and I'm not saying that it does heart attack prediction because I think that probably it doesn't. But what I think is so cool about this little teeny sensor is that it's a non-verticent function of heart function. So thinking about how do you implant this little thing under the skin to monitor heart function all the time. I mean, it's just such an amazing thing. And people are, if they're having heart troubles, they're worried about it. You can imagine that there's a behavioral and social issue. How do we help them? How do we get feedback in real time? How do we know how they're going? And so this is one of the tools I think that will help us get there. We can do molecular analysis. This is a tool that Rod Pettigrew, who's the director of the National Institute of Bioimaging and Bioengineering, he loves this one. He thinks this is just the best thing in the world. I can honestly say that I'm not really sure what it does, but it's really, really cool. So it's a little lab on a chip, but you can see it's coming into your smartphone. We could do this, and this thing is fast, and this thing is accurate. And so think about how we can do things in the real world in real time. And so it's just pretty amazing. And it looks way cool too. So These are some of my favorite, the Nanosensor Tattoos coming out. Thinking about how do we use these little tattoos. You've all put them on your kid, you get them wet, you stick them on, right? It's just a simple gel. But if we put nanosensors in them, we can do EMG, we can do, there's one for sodium being developed now. And anybody that's ever tried to measure sodium, we usually do it by self-report or through urine. These are not, self-report is not good, urine is not easy. So if we can actually start to measure sodium non-invasively, way cool. And besides, we could get little pirate tattoos out of this and still do science. So I don't know how we could lose. We think about treatment. Dave's here. See, Dave, you're my slides. Well, I think chess is a great example of chronic disease management and some of the things that we can do. And Dave Gustafson in Wisconsin has done amazing things, and I know he's working with you all up at Dartmouth, and that's so cool. But he really has done the system, this really comprehensive system, but bringing in caregivers, patients, giving them tools in real time. And I think that's some of the models we really should be thinking about in treatment. For cardiac disease management, this is one from Vladimir Schusterman. He's at Pittsburgh and has a company called PinMed. But he's actually trying to do, he's doing a single sensor blood pressure right now. He does all sorts of way cool cardiac stuff. But what I think is really interesting is he's creating individual fingerprints, he calls them, of function. So instead of saying, how does my heart function compared to the average person, he's really trying to create a personalized heart function. So am I functioning compared to myself? Because I don't really care if I compare to the average, right? And probably if I'm managing high heart function, I'm not average, right? Most people don't go around measuring their heart function. So you're not average at that point. But with his, you can find out, you can get a text message saying, I think something's going on. It goes to your care provider. But also, if you feel like something's funny, you can also look at your readings and say, oh, all right, maybe I'm okay. And if you've ever worked with people who have like panic attacks, they're having symptoms, but their emotional response to symptoms escalates everything. So you can imagine with this, if you're getting real-time feedback, that people may de-escalate. And you may reduce unnecessary hospitalizations, all sorts of things. This is Donna Sproutmatz from USC, who's working with low-income kids, low-income and Hispanic kids in UCLA. But she does a body sensor network, and we can do this for so many things. But to get feedback, we can do it for rehab, we can do it for, we can do it for anything. You guys probably know better than I do all the things you could use them for. But this is just a simple system, or not simple system. It's a complex system that operates in a very simple way. So kids can get text messages and say, get off your butt. Because the kids did not, by the way, just for the behavioral and social factors, they didn't want messages like, you need to get active now. That didn't work for 10 through 11-year-olds. Get off your butt, you're getting fat. Those messages worked. And so we really need science around this. What are the messaging we should do? Should it be one way? Should it be two-way? How often should it be? What's the saturation point? Does it differ? How do we think about this? We don't really know any of that at this point, and we make generalizations. I was just talking at a meeting at NIH, and I was talking about Lester's work on WellTel, which is this fabulous text messaging study to improve antiretroviral adherence, and it's just fabulous. Great effect, really improved all the, even for the health outcomes, great. But it was a very well done study where a nurse, a care provider sent a single word, something like, how you doing? And then you had to respond back within 48 hours. But that's now been taken to say that two-way communication is required for everything. It was a great study, but it never tested directionality. So, we really need to think about that. In the global sphere, I guess I don't really have to make a case for this here, but I always really try to get people to think about it's fun, it's interesting, and we can learn so much from what's happening in that world. And they don't have a healthcare system like we do, where you're trying to work around some of the issues we have. And so that leads to opportunities to be creative and do amazing things. This is one in Uganda. This is Jessica Haber from Partners, and working with Dave Bangsberg, so doing adherence monitoring. And if Jessica was here, she could show you this woman's medication adherence in real time. If she was taking a pill, and this thing is actually built in a garage in Uganda. So it's just a little thing, it has the pills in it, you open it up, it sends a signal. So they've done some really nice work in working with this community. So how do you increase adherence? Because adherence is a question of life or death in HIV. This is another one in Peru, and I think, again, this is an example of how you can use reverse technology transfer. This is Walter Curioso's work. And I think what's really interesting is he did this with prostitutes, although I'm not supposed to say that because, you know, it's a weird world nowadays. But what's really interesting is they go in for medications because they get exposed to disease. And you don't want them to have their diseases because then it spreads, right? So it's a public health issue. So they go in, but if they have an adverse event, they stop taking their medication, right? Which spreads disease. But, you know, since they're a marginalized population, do you think they come back to the doctor and say, by the way, the pill you gave me made me sicker? No, right? And you can think about how we could use this in this country. And so they created this automatic interactive voice response system where if you're having an adverse event, you call this thing, you put in, you don't have to talk to a real person, but actually you'll get new meds at the clinic. Your meds will be changed out at the clinic. But, and that's the end of the message. But it goes to this database so the doctors can see, are they having an adverse event? So not only does the woman get treated, or the man who gets treated, but you get to know it on a public health level. So it's really cheap and very interesting. And you can see where it could be applicable in many different ways. I also think this was a trial from Pfizer. It died. It didn't actually work. They tried to do it on Facebook and Twitter, and I wonder if drug trials are not a good thing to do on Facebook and Twitter. From my behavioral and social spec standpoint, I can imagine why Pfizer trials on social media might be a problem. But I think the potential for remote trials is huge. This was actually overactive bladder. It was an FDA-approved trial, and it had been cleared. The medication was cleared already, so they did a third arm to the trial where they did it remotely. And I think, you know, this for academics who understand how to work and who do not have some of the baggage pharma has, I think some of these remote trials will be amazing. And I think it's going to really change the way we think about health. So the challenge in this, I mean, I told you I drank the Kool-Aid, but there are challenges. There are really some hard things to think about. The Wordle is just all the cell phone companies around the world kind of mushed together. But, you know, thinking about tech development and research timelines, my colleague Bill Riley from NIH was here. He would show you his little thing about how if you started your RCT in 2005, you would have missed YouTube, the iPhone, Android, everything would have been missed. Those 5-year RCTs are a killer. I think that I would encourage people not to throw out RCTs. Don't throw out the baby with the bathwater. I think we need to work on quicker research designs. I think we need to be more nimble. We all know that. And I think doing the science and the methods is really important. But I also think that we really need to work together on this. We really need to figure out timelines that make sense. And tech is going to need to slow down a little. And we're going to need to speed up a little in the research world. I think there's an issue with the heterogeneity of devices. You know, devices are, I mean, if we in health now get to benefit from using way cool devices that we could have never built in the health setting, right? If you think of the phone as a small computer, could we have ever built anything that cool in health? No, never, right? We're always on a budget. So now we can work with this fabulous, cool processor. It does all sorts of things and can transmit data, use it, you know, as a hub for sending signals. Really great, but we have so many devices that are changing so many times. We have multiple operating systems, which we never know. We know we'll have Android and Apple. We never know who else will be in that game. But the operating systems are updating. So thinking about this, I mean, we don't have interoperability yet. I'm working with NIST. I'm working with FDA, Continuum, all of those. We're all talking. We're all working. FDA actually has an interoperability group thinking about that, but you know, it's really a challenge. And standards. We have HL7, which is people are now talking about. There are so many standards and there are so many issues in this, and I think we need to get there. I think there's some logistical barriers to scaling in the U.S. especially. There's been some challenges. The guidance on mobile cybersecurity and privacy, I'm so glad you all have been leading here at Dartmouth in this area. But this is such a challenge. When I go down and talk to my colleagues at the Office of the National Health Coordinator for Health IT, they say, oh, yeah, we did a focus group. on mobile? And I say, yeah, what'd you talk about? And they say, EHRs coming through your phone. Well, health is so much more than electronic health records. So we really need to create a science around this. We really need to know what kind of questions people are asking, what they wanted, and what's the value to them. Because we were talking about at dinner last night, I'm really concerned that the barrier, the level of privacy and security we have in our phones and our wireless world is not what we think it is. There's a study out of Berkeley that showed that people think all their information is secure and private on their phones. But then when we go in with health, we say, oh, and by the way, this, and we hand them a consent form of all the things that are going to go wrong. And they go, oh, my regular phone is secure, it's private, and look what you're doing to me. We look horrible. We look horrible. We have health all the way up here, and we think the rest of the world's down here. And it's true, we're higher than the rest of the world. But the reality is people don't understand privacy and security in a mobile space anyways. So we really need to think about how do we frame this in a relative way so that we don't stifle creativity and we don't keep people so safe they die. I've heard people talk about, the car as a great example of something that causes thousands and thousands of deaths per year. But, it's something that's changed the way humans interact with the world. So thinking about how do we balance those issues. IRB and HIPAA, this is a constantly moving target. They redid HIPAA this year. IRB, they are redoing the common rule. It will be out shortly. That is the main rule that your IRBs work by. That's being revised right now from HHS. I'm going to change some of the things. Some will make some areas easier. It will make some areas harder. But it will throw everything into confusion any way we look at it. But I also think that we have to spend some time teaching our IRBs, and we really need to work with HIPAA. They added some mobile language in this revision, but I don't think they really, I think HIPAA seems to be the rule we all operate under because we're often at covered entities, but often it's not a HIPAA type topic we're working in, so it's really important. And I think the other thing that to me is really important is how do we engage people remotely? We think there's this potential to let people, they can do their trials in their home, they can, we can monitor them at home, we can do all this stuff, but how do we really engage them? Look at the devices that are bought now. Look at the data on apps. Susanna Fox's, work on apps. People download them. What is it? Something like 74% never even get opened. 24% get used once. How do we get people to want what we're doing, want to use our sensors, want to use our systems, want to use what we're doing, and open it again and again and again, or not need to open it and have it function and be useful to them in the real world. But we don't really know how to do that yet. We don't know what kind of rewards we need, what kind of feedback. We don't even really know how to present data to them yet. I'm still seeing things where there's tons of text coming through. And with technology now, we can present a whole lot. We can do it in a whole lot different ways. So if you're interested in methods, I always put this one up. This was a project that we did with Robert Wood Johnson, NSF, McKesson Foundation. The paper will be coming out in August, so look for that at the Journal of Preventive Medicine. But if you want to see this was actually, if you're interested in methods in mobile and wireless, this conference was a day-long conference that we videotaped the entire thing, and it's on our website. But it's really looking at some of the questions, how do we get around, how do we speed up trials, how do we look at alternative designs, all of those questions. We also do training institutes. I know I've talked to a bunch of you about them. We do not only do early stage people, we now do people across the lifespan. We actually did a distinguished professor in our last cohort. Our trainings are really designed to bring people together just like this group, to bring people together across. We do a lot of teamwork, a lot of team training. It's fun, it's exhausting. Dave will tell you, he was faculty once. It's totally exhausting, but it's very fun, and we have seen a huge increase in the amount of grants that get done with people who, Jacob was there. Oh, and Bree was there too. So thinking about, they're exhausting, right? Am I correct? Yes, so okay, good. I'd like to know it wasn't just me, maybe I'm just old. Misha would probably agree too. But the thing is that what they do is they let people really work together for a week. And if you're not in a situation where you have the interdisciplinary collaboration, we actually do a quarter medical, quarter behavioral and social sciences, a quarter computer science, and a quarter engineering. So it's very different than our usual NIH training. And people determine their own projects. They work together. We've seen a slew of grants developed. And we've also seen a slew of grants being developed with the faculty. So people across their levels have something to add. It's very fun. We also have a listserv. I always encourage people to consider our listserv. I run it. It's moderated because otherwise people send up, please join me up, and everybody hates that. So I moderate the listserv, but it's all sorts of weird stuff. It's all sorts of funding announcements. It's all sorts of things that you may be interested in. So if you're not on it, you might find it useful. And that's it.
We have about 15 minutes for questions, and just a reminder that this is being recorded, so we ask you to talk into a microphone. The microphones will be passed around if you have a question.
Can you just go back to the slide with the
Okay. And if you're interested in any of the things listed on the slides, if you search for OBSSR mHealth, you will hit our webpage. It's much easier than trying to actually look it up on you can see. We don't do very good with tiny URLs. We're the government. We don't do that. So I always get yelled at when I make tiny URLs, so we don't do it. But if you search OBSSR mHealth, you will find us. And you will find all sorts of goodies, because we put up everything we can think of. No question. I was so well trained. It stopped exactly. Okay, here.
So I'm Ashu from Rice University. So there is a, so from what I gather from medicine, I've been into health only for 3-4 years now, engineer by training, and there is this desire to actually define things so that they are full defined protocols, right, in medicine, I would say, or that's my understanding. And some of that I got from your slides. So I'm kind of playing devil's advocate. But in technology, the way technology progresses is by constant change. Like, just disrupting their own businesses is how companies move forward. So there will be no getting there, right? So in this case, actually, it looks like somehow, actually, I don't know what the solution is, but if we want to use constantly moving, changing technology, that means everybody has to just keep up with this thing at a constant pace. Right. So do you have any thoughts on that there is no getting there? This is like a constant race we've always been.
Right. No, if I had talked about methods more, I would have gotten at that. Because and actually, if you think about medicine, that's true, right? You would hope your physician didn't do what he got trained to do, or she got trained to do when she graduated from school, and then stayed there forever. Wouldn't that be disgusting? It'd be horrible. Right? They should keep up. They should keep changing. They should keep, okay, wait, this test is no good. This medicine's better, right? That's real life. So there are some designs now being evaluated. Like there's a it's CEEI, continuous evolving evaluation. So I think there really is a need for methods that can continuously evaluate. There's designs now. There's some smart methodology that comes out of engineering. Susan Murphy at Michigan, where you continuously adapt a trial as you're over time. So if you haven't looked at Linda Collins, she does the multi-phase optimization strategy at Penn State, and then Susan Murphy at Michigan. So I think what you're getting at is reality, and it's total reality. And NIH would like to think we'll run an RCT and we're done, and then we disseminate it. And as you can see, it takes 17 years to get stuff out into the world. It's not work. And I think we all know this. And in mobile, it's really kind of fun because we're upstarts, right? We're kind of, we're the spunky little upstarts of NIH. So people are giving us a lot of slack on thinking about methods. So I think this is a huge area, and it's a huge area of science. And we need engineering and computer science really to come in and think about what methods they've done. I'm talking to modelers who evaluate software, and they run these models where they churn through, they create avatars and then churn through millions of interactions. Think about that in health. We get patients. Why not simulate them? Isn't that a cool idea? But we haven't gotten to this yet, but we can. So I think that's what's exciting. That's what keeps me up nights. But I think these are real, I mean, they're real challenges, but I think they're really opportunities to think new things. So.
Hi, Hamish Fraser. I work at Harvard Medical School and Partners in Health, and I've also been doing a lot of work with the Mobile Health Alliance and with Paddy from last night. So I was interested in your comment about WellTel, this is the system for text messaging, to support adherence or whatever you want to call it for patients in Kenya. It seems like, well, we've had a big debate about this, and it seems like there is a lot to learn about what actually helps to ensure adherence. And so some of the studies I've seen, for example, working more with community healthcare workers, if you don't have some kind of a two-way process and a follow-up with them, then over time the impact falls off. Right. And Neil Lesh, one of my colleagues in Boston, has done some studies looking at that. And then there's the whole question of how you craft these messages, and the evidence from, I think, Jessica Haber's study with David Bangsberg, where basically, if the message was small, short, and once a week, it was good. But if it was longer and more frequent, then it wasn't so good. It seems like, although we have some little points of evidence, there's the whole area of how do you actually scale this, replicate it, or maybe make it work well for more than one type of alert. Right.
So you're so right. And this is so prime for research. And I think, we're trying to figure out how do we support this in NIH, because it's not an easy area for NIH to do, because it's really, it's health communication, but these are really small, nimble studies to try to kind of get to some of these things. Because these questions are huge. If you're doing text messaging to youth in America, I mean, I've seen studies where up to 6 times a day. And the kids like that. But, if you're doing it in Uganda, where, those messages cost money, or you don't have the phone every day, or, all of these things, what do you do? But so there's going to be cultural differences, but there are going to be some basic principles that we can learn from and that we can use then to enhance our work. So I think it's great. It's great. It's a significant problem, but it's a great opportunity for good science.
So this is Lakshmi from NYU. We were talking on the way while getting coffee.
He was my coffee buddy this morning.
So coming on to a more sort of fundamental but very basic question of how do you get computer science and engineers to work with health people, especially from an execution standpoint of, maybe NIH talking to NSF, or how do you really get these? I've been trying to work a lot with health folks from NYU, and we talk different languages, and we have our own set of priorities. Sometimes I've had Ph.D. students invested a lot in health, and they end up realizing that this is not a computer science research problem, and just getting this ecosystem up and running seems to be a fairly big challenge. So any thoughts? And also, how do you handle joint funding from NIH related things? So just operational question on how should we move forward as a community?
So the easy part of that, and Misha and I are very proud that we have a joint announcement between NIH and NSF. It's called Smart and Connected Health. It's more than one submission date. We worked, we sold our soul to the lawyers, we made it work. So that is one way we're really getting there. But the other thing is, I was talking to Andrew before and Lisa, you have to be willing to feel stupid. I went to a pervasive health meeting and NSF funded, and Andrew was one of the co-chairs. And I actually didn't want to go because I knew I'd feel stupid. They were talking their computer science, talking at this high level. No, Andrew, it was a great meeting. But I felt stupid. I remember one engineering meeting where I finally put my head down on the table. I'm like, I can't do this anymore. One more algorithm that I don't understand. And this guy next to me says, you're not an engineer, are you? I said, no. It turned out he was a software developer and was so between worlds. So he said, let me explain it to you. And that was great. But sometimes it's willing to feel stupid. And it's but it's really understanding other people. I think your point about it's not a computer science question, I work with computer scientists all the time, and even if you save the world, if it's not a novel computer science question, you don't get rewarded for it. Your student's not going to get tenure. I mean, maybe if they get the Nobel Prize, they would, but for most of the problems health has, they're pretty basic computer science questions. I mean, they're not tenurable questions, right? But we can break anything you can build in health. And we need to work together, but it's how do you figure out what are the pieces that you can work on and get rewarded for? What are the pieces that I can work on and get rewarded for? But it's really having some honest conversations. When we're working in the trainings, we're finding people are collaborating now. And we'll have my health folks going for an NIH grant and putting the engineers and computer scientists on as investigators and co-PIs. And then the same is happening for NSF. They're working, so they're actually supporting each other, which is really healthy in this incredibly tight fiscal time. But they're learning how to work together, and they're also realizing, oh, I can present at a conference proceeding, you can, and get rewarded for that. Well, I can't. Well, I could in NIH, but I can't in my academic self, right? But I can go to a health conference and present an aspect of a project, so we can actually double win. But we're going to have to teach everybody about that. We're going to have to really stop and talk. And I think meetings like this are a great way to really push that together. And, frankly, money's tight. We did the Smart and Connected Health as a way to get your deans and your presidents and everybody to say, ooh, maybe they should come together. I mean, I know there's actually some universities that are now co-locating engineering in with the medical school or with public health. Computer science, moving them in together because, money's tight. And if you have to figure out new sources, you're going to have to train in different ways. So, Misha, you want to add to that? No, he doesn't. He's smiling. He and I have been, this is our mission, is to get everybody to really work together. And, the other thing is what's huge is you make us better. I mean, we were talking about this over coffee. We used to think of engineers and computer science as technicians, and you guys think of us as clinicians. And really what we are is people academics. So we really need to come together in that way because, my engineering friends say, what does that mean? I'm talking about vigorous physical activity. Well, to an engineer, that doesn't mean squat. Tell me what it looks like. I mean, one of the reasons diabetes is done well in wireless is because we have numbers. We have hard cutoffs for hemoglobin A1C, right? But most of health is sloppy, right? Like, when do you have cancer? When do you not have cancer? When do you have heart disease? I mean, it's not a number. So, we have to really start to be able to specify in health. And we have to specify in behavior. When are you adhering? I work with Kevin Volpe at Penn State, who's doing this huge CNS trial. And he's got people that are on 8 meds and they have flow caps on every model. And he says, so if they don't take one med, do we contact them? But they take 7 others? If they take 8 meds twice a day, but they only take 7 the third time, do we contact them? What is adherence, even adherence? So I think that we have to start to work together to specify, become more accurate, and tighten all these things up.
Wendy, I think this kind of fits on the last 2 comments on evidence and then how to work together. Because as a social scientist, sometimes I think we come to the health communication, the behavioral issues in health and say, boy, there's a lot of literature on how you communicate with people when you get fatigue in messages, when you, how to motivate certain kinds of behavior change, the anthropologist, the sociologist, the social psychologist. So it's not unlike the computer scientist that sometimes it looks like, well, that's a question we've already addressed. But the literature isn't known by the clinical community, and sometimes that's frustrating. It's hard to get the grant when the clinicians review it and say, oh, well, this hasn't been applied in this field or this area. So there's some of those, I think, multidisciplinary issues. But then it's also trying to figure out what we already know, but when it's applied in this new area, it leads to a whole set of new questions, not just about the health, but about the social science that we also want to advance for our own careers and the theoretical questions there. And I've been doing this for a while now too, and it does take a lot of conversations, but it also still, every once in a while, you get, it's still frustrating. Like
Yes.
all of the efforts you're doing on NSF and NIH and bringing it together, it still many times is not. It ends up sending people just like, well, I'm just going to go back to doing what I was doing, and so I know you're already doing lots of things, so I don't know what, but how do we keep motivating people currently doing it and even bring in the new people is sort of the question.
Well, and I think Misha's going to say something too, but Misha, you want to say something?
Yeah, I was going to say that one of our, can you guys hear me? I'm not sure that you're hearing me.
No, we can hear you.
Okay, good. One of the thrusts of this joint program is to build what we call transdisciplinary teams. It's teams of people who actually don't bang their head when there is algorithm talk or when there is a molecular talk. But and there are many ways of doing it. Having computer scientists to come to grand rounds and having biologists and medical scientists explain algorithms, do a review papers, seminars, where actually you're not explaining your own work, but that work of the other group actually works quite well, but it's very hard. It's not easy to do.
I think, and I agree with Misha, and I know there's frustration. I mean, it's not easy, and I work long hours trying to make this better. I think talking to us, sometimes I get people, the other day I got a grant application. It was being submitted that afternoon, and this engineer sent it to me. It was a great idea. There was no way in God we were going to fund this thing. Because it was written as an NSF grant. And it was really smart and really good. But he's like, do you have any ideas what study section to send this to? And I couldn't say none. But I really wanted to say, no, please don't submit this. But if you talk to us early, and if we don't answer the first time, ping me again. I'm always bopping around somewhere. But I want to talk to you. I want to work with you. I want to connect you to people. And I want to help you build the languages and the teams. I also will connect you with folks. I'm a connect the dot lady. So, you'll say, oh, I need somebody that's doing this. And I'll say, oh, wait, there's somebody. Hold on, let me see. It's someone so here. Let me connect. I'm always sending people to Dave. I sent somebody to Lisa just the other day. Here, you meet Lisa. She's wonderful. And she's like, oh my gosh, what are we doing? But I usually, I connect you with people who I think are going to really be positive. But sometimes it's we want to work with you on these things. We want to help. We want to make sure the good science gets through.
And it's important. Let me just add to this that it's important for every member of the team to understand the other groups in the team. And when I get an engineer or a computer scientist, and I ask them, well, how does this work? And they will say, oh, you have to ask the clinician. That's not the right answer. You really have to be acculturated. And it's difficult to do, but it's necessary in order to make real progress.
Okay, we're out of time. So thank you, everybody.